Hello everyone, welcome to our 39th Libyan cardiovascular webinar. Today we're going to run ECG round. This is our first experience with broadcasting live on Facebook, so we apologize in advance if we have any technical issues. We're just waiting another 10 seconds for more audience to join us. Today, we have three presenter, myself, Khalid, Abozguia, cardiologist from the UK. We also have my colleagues, Dr. Yousef of Darrat, cardiologist in the US, and my colleagues, Dr. Fathi Idris, cardiologist in the US. Today's session will be an interactive session with focus on ECG. Please feel free to use the chat box to ask any questions. If you want any clarifications, we try to make it an interactive. Again, this is our first experience using broadcasting live on Facebook, and so we'll appreciate any feedback, and hopefully our next meeting will be much better. So without any delay, I'm going to introduce our first speaker today, Dr. Yousef of Darrat, cardiologist from the US. The way we're going to run the meeting today is each speaker is going to present one case, and then we will move on to the next speaker. So it will be more interactive. So Dr. Yousef Darrat, the floor is yours.
Assalamu alaikum. Thanks for joining us today. We hope that this will be a very beneficial education experience for everyone. Our main focus, of course, will be ECGs, and so we'll present some ECGs, give you some time to look over the EKGs, and then provide you with options. Please type in the choices or your choice in the comment box on Facebook, and then we'll go over the answers. So ECG number one, so I'll give you a few seconds, maybe about 20-30 seconds, just to go over the EKG, and then I'll go over the options. There's going to be four different choices, and I'll go back to the EKG so you can take one more look, and then please type in the answer in the chat box on Facebook. So the options are as follows. So a 68-year-old male presents to the ER with chest pain and dizziness. The ECG shows sinus bradycardia and left bundle branch block, sinus tachycardia, AV block, escape rhythm, and myocardial infarct, sinus bradycardia, AV block, and myocardial infarct. And then option number 4 is sinus bradycardia and myocardial infarct. So I'll go back to the EKG. Go back, take a look at the EKG. I'll read you the options while you're looking at the EKG. That might make it easier for you to make the choice. So sinus bradycardia and left bundle, sinus tachycardia, AV block, escape rhythm, and myocardial infarct, sinus bradycardia, AV block, and myocardial infarct, or sinus bradycardia and myocardial infarct. Okay, we have an option 3. Chosen. Okay. So so this is the ECG, and I'm showing here some arrows to explain the findings. So the right answer is actually Number Two, which is sinus tachycardia, AV block, escape rhythm, and myocardial infarct. And I'll explain why that is the right answer. So first of all, you can see some P waves here. And if you look at the arrow, there's a P wave here, a P wave here, another P wave which is kind of hidden in the QRS complex, and then another here, another here, and so forth. There's another P wave actually here. So if you look at this rate, so it's sinus rhythm, we think that this is sinus rhythm. There's a positive P wave morphology in lead 2, kind of almost biphasical positive in lead 1. So we think that this is sinus tachycardia, and the heart rate is fast. So that's why we chose the right answer would be sinus tachycardia. So there's AV dissociation, as you can see. So this is complete heart block with a junctional escape rhythm, very regular rhythm, junctional escape, very slow, and a myocardial infarct. And the reason we say myocardial infarct, if you look here at this lead, there's an ST elevation, and there's a Q wave actually, so it's an infarct pattern with some reciprocal changes in lead V2 and V3. So this is an inferior wall MI. So that's why this would be the right answer. So I'll move forward to this EKG, which is from the same patient. This EKG kind of further clarifies that this is a myocardial infarct. You can see the ST segment elevation in the inferior leads. Also note here that there's also a P wave and a P wave, so there's some dissociation. So this is an accelerated idioventricular rhythm that happened. Could be a sign of reperfusion. So again, the right answer, just to go over it again, it's number 2, which is sinus tachycardia, AV block, escape rhythm, and myocardial infarct. If you have any questions, you can type it in, and then we can go over that EKG. But we'll leave those questions actually later on. Khalid, I think it's time for you to present your part, or Fathi.
Okay, thank you, Yousef. I'm going to go to my presentation now. Right. Our first case is a 68-year-old female who had a past medical history of COPD, asthma, but also described a hole in the heart as a child, but did not require any intervention. She also had a background of hypertension, presented to the ER with palpitation and cough, and that's her resting ECG. Sorry, that's her ECG during tachycardia. So based on that ECG, what would you do next? Would you start this patient on anticoagulation, do a transthoracic echo and then cardivert, or whether you will do a TOE and then cardivert, or whether you consider this patient for ablation, or you will do nothing? So I'll show you the ECG again. So I'll give you a few seconds, and if you could type your answer in the chat box. Again, based on this ECG in a patient who's complaining of palpitation, would you start the patient on anticoagulation, do an echo, and then electrical cardioversion, or whether you will do a TE and then cardivert the patient, or whether you consider the patient for ablation, or you will do none of the above? So we'll go to the same ECG. You initially get the impression on first look that there is some flutter waves. You could see it mainly in lead 2 and lead 1. but when you focus on the chest lead, you could clearly see a clear P wave, sinus rhythm with left bundle morphology. So this is just P wave. There is no evidence of flutter here. More importantly, on this, I put the rhythm strip at the bottom there. So if you could focus on V5, you could see that V5 shows clearly sinus tachycardia with P wave, one-to-one relationship, no evidence of any other activity, which means what you seems to be a flutter waves on lead 2 is actually an artifact. And this is, again, by experience, it's not physiological because it's variable in morphology and it's very rapid. And clearly, when you compare the chest lead, it's clearly sinus tachycardia with.
This conference is being recorded.
So basically, this patient does not require any anticoagulations, and patient just had a chest infection in the background of COPD, required antibiotic, and patient settled, and heart rate came down to normal sinus rhythm, and also the patient was investigated further for the left bundle. So this is just a typical example of just avoiding interpretation of artifact as a flutter, which is not uncommon. You see it in patients with Parkinson's disease, or if there is any interaction with the recording machine. So just be careful and examine all leads. And if you are in doubt, repeat the ECG again with the different rhythm strip if in doubt. So this is just a quick case. If there is no questions on the chat box, we will move to, let's just give you another 5-10 seconds, see if there is any questions on Facebook.
Khalid, can I interject for a second? Very nice case. Can you hear me, Khalid?
Yes, Fathi, do you want to go next?
No, I'm about this case. So can you speculate what's the artifact coming from based on this? What's the possible, can we tell whether this is coming from a electrical source nearby or body tremors or anything in any way to speculate, or that's hard based on this EKG?
Based on the EKG, it's hard, but I think knowing the patient it's likely to be electrical interference. But I honestly don't know. But it's clear that when you look at chest lead, it's sinus rhythm. Any comments, Fathi, from you?
No.
I think I would like to add something. I was thinking, just looking at the EKG, since it's in the lymph leads, it could be tremors. But in the precordial leads, you don't see anything. It's nice sinus rhythm. So, without my interpretation that this could be some tremors, because it's mostly in the lymph leads.
Yeah, that makes sense.
I think a very good point. But I don't. From my recollection of the patient, I think she was relatively healthy, and I don't think she had a tremor. But could it be just she's nervous while she was doing the ECG and moving? And it could be, yes.
Right.
Very valid point.
Very interesting, because the bigger the muscle involves in the artifact, at least it's my experience, the bigger the waves you see them, and then becomes, instead of a fib artifact, becomes a VT or VF artifact and gets more scary. And I'm sure all of you have seen those before. So very interesting, Khalid. I like it. Do you have any questions? I don't see any questions on Facebook about this. So
I think you could go next now.
Hopefully. Okay. So just pull my slide. Okay. So I have no disclosures. So first case, this is a 37-year-old Hispanic female who presented to the emergency room with chest pain. So this is her EKG when she came to the emergency room. And in fact, there's no questions about this EKG. To me, this EKG looks pretty normal. I don't see any, of course, if somebody comes with chest pain, you worry about ischemia or infarct or whatever. But if somebody who's young, female, makes ischemia not high on the differential diagnosis. So for me, this looks like a normal EKG. What do you think, guys? Khalid and Yousef, you think normal overall, or?
Yeah, I agree. It looks like a normal ECG.
Okay.
When there's some sinus, 1, 2, 3, 4,
Yeah.
sinus rhythm.
Yeah, sinus rhythm. A little bit, I thought, well, a little short PR interval here, but, well, let me just use my pointer, sorry. I thought the PR is a little bit short here, but again, it's not a big deal, I think. So this is her EKG when she first presented. And then about half an hour or so later on, this was her EKG. So I want to give the audience a minute or so just to look at the EKG, or less than a minute, hopefully. This doesn't need a minute to recognize this, right? So rhythm is still sinus rhythm. It's still kind of bradycardic, but I think the most prominent abnormality you can see there is ST segment elevation in several leads, including anterior as well as inferior leads. So so this would be abnormal EKG, I assume. There is a PVC there. I think everybody's cannot miss that. There is a PVC here, happens at after the termination of the T wave, but clearly there's ST segment elevation. So I think everybody should have seen this for now. So the question I have is, what is the underlying problem in this patient? Is it hyperkalemia, Brugada syndrome, or actually, let me, okay, so I'm sorry, apologize about the confusion. So is it, yeah, hyperkalemia, Brugada syndrome, or acute septal MI? So these are, or acute MI instead of septal MI. So go back to the EKG. I think I have the questions for both are a little mixed up, but anyway, you can still comment about this. So we'll give a few seconds for any comments or any answers. Let me choose the so again, the comment would be ST segment elevation inferiorly and anteriorly. And the question, what's the cause of this problem? So skip this. And then the patient was given sublingual nitroglycerin. That's the only thing was given. And this is the EKG after sublingual nitroglycerin. So shortly after sublingual nitroglycerin, the EKG is, as you can see here, is pretty much normalized. So the fact that the patient has dramatic ST segment changes over a short period of time makes hyperkalemia unlikely and doesn't fit Brugada syndrome. The fact that ST segment went up quickly and then with just sublingual nitroglycerin resolve the problem indicate this is just, of course, you have to treat as an acute current of injury or MI, but always try to give some sublingual nitroglycerin because this will differentiate the underlying mechanism for the ischemia. So given the sublingual nitroglycerin resolve the EKG changes immediately, indicate that this is a coronary vasospasm. So this was a case, or this is a case of a coronary vasospasm in a young female. A couple of comments about coronary vasospasm. Although we always feel it's a benign condition, and generally speaking, is benign when treated appropriately. So here's the same patient in the emergency department, and you can see sinus rhythm, no problems with sinus rhythm, no ST segment problems, and then a couple of hours later, she started having some PVCs. As you can see, there's some PVC occurs at the end of the QRS complex after the T wave. And you can see here there's ST segment elevation. So if you look at the baseline of this EKG compared to that EKG, so there's ST segment elevation, and also there's some PVCs. But just I want you to focus on the location of the PVC. So this PVC happened at the end of the T wave. This PVC happened at the descending portion of the T wave and created another PVC with it. So kind of two beats. And then the ST segment still up, and another PVC here, and then another PVC, and that all happened in the context of spasm. And then later on, bad things happened. So patient went to ventricular fibrillation, and then eventually needed electrical cardioversion to put the patient back in sinus rhythm. So this just to demonstrate the natural history of spasm. Not all spasm are easy and benign. You need to be careful as it may lead to certain bad arrhythmias. So this is in summary a 37-year-old lady with EKG changes described as segment elevation consistent with the spasm. This is my part. Khalid, Yousef, any comments or any questions?
Very interesting case. Yeah, Fathi, I had a similar case like this before, and we were debating. It's outside the scope of this presentation whether the patient needs an ICD or not. But how did you manage this patient?
So,
is calcium channel blocker? You think calcium channel blocker would be enough?
No. Of course, I got this case because of my interventional hat, not because of my EP hat. So this was led to activation of code STEMI, was brought to the cardiac cath lab. And interestingly, she had a lesion of about 60%, not more than 60, maybe 70% at most in the LAD. So a partner stented that lesion, and after stenting that lesion, we put the patient on both calcium channel blockers as well as nitroglycerin. And of course, on high-dose atorvastatin, aspirin, and Plavix. And she did fantastic. I think a year and a half after that, she was doing fine. No more ischemia or no more chest pains. The problem, Yousef, is spasm. Typically, it can happen in purely normal arteries, but it also, most of the time, it occurs on a borderline lesion. So the time does not permit, but I have the OCT images of this lady. So she had a burden of atherosclerosis in that LAD lesion, which I believe that led to the provocation of a spasm on a background of atherosclerosis. So I think treatment of atherosclerosis or underlying atherosclerosis aggressively, in addition to treating any borderline lesions, it's important. But again, close follow-up. Many of those don't need an ICD, although cases who needed the ICD are well reported in spasm, bad cases of spasm.
We have a question from Sliman. How can you explain short PR interval, just to make sure we don't miss it?
Yeah, so that's an interesting question. So if you go to the basic EKG, remember short PR interval, it does not necessarily always mean pre-excitation of Wolff-Parkinson-White syndrome. It just indicates that the patient's AV node is so slick and maybe have a short and like a fast pathway, and does not necessarily mean that the patient has any Wolff-Parkinson-White syndrome or anything. It's just high catecholamine or very slick AV node. It can give you short PR interval. As long as there's no other evidence of pre-excitation, short PR interval is a benign condition. In the past, I think they used to label it LGL syndrome, which is simply may indicate the patient has fast pathway, and if the patient have a slow pathway, and then they're more prone to have some sort of AV node or entry tachycardia. But it doesn't mean much. This would be my interpretation. Do you have comments, Khalid or Yousef, about the short PR interval? I think there's another question.
Yeah, Fathi, just before you go to the last question, I agree. I think a short PR interval, essentially, if you think about it physiologically, it's the distance from the sinus node firing all the way you activating the ventricle through the AV node. So if you have an AV node slick, and you see it very commonly in young patients, and I think your patient was young, Fathi, is that correct?
Yes, 37.
Yeah. So in young patients, their AV node, we call it slick or enhanced AV node. So it's very common, we see it a lot. And as long as there is no evidence of delta wave or pre-excitation of the ventricular signal, usually short PR interval is a normal finding in young patient. However, if the patient is symptomatic, then there may be need for investigating. But I agree, short PR interval alone without evidence of delta wave or pre-excitation in young patient is something we commonly see these days. But I think there is another question for you about, which is, it's a very, very good point actually, because this PVC, I mean, has she had a 24-hour tape about PVC burden after her intervention?
Yeah, so this is a question. It's a loaded question. So there's a question about beta blockers, which is an interesting question in the context of spasm, because people with spasm, the classical teachings has been always avoid beta blockers because they make spasm worse. At least this is what I was told during early on training. And I don't think there is a good answer to. I think if you want to use the beta blocker, you can use them cautiously if you need to. But in this patient, for example, if you can use a calcium channel blocker for whatever reason, for treating blood pressure or treating the spasm itself, etc., I would err more on the calcium channel blockers. This is about the beta blockers. In regards to the PVCs, I think these PVCs are not your normal outflow tract PVC or those PVCs you're going to chase later on for several reasons. Number one, I just brought the EKG back to the monitor. These PVCs, to me, looks like ischemia related because the location, the coupling interval is quite variable. So you see the coupling interval here, it's after ST elevation, coupling interval here is different from this one here, which is, this is a classical RMT. That's what I think put her on VF second time. And then here, it's quite far. And then here, back on the downslope part of the T wave. So these are not your classical, uniform PVCs having from the outflow tract to the right or left, and you treat them by beta blockers or other agents. So I did not do an event monitor on her. Khalid, to answer your question, her ejection fraction has been normal and she never had any problem with that. So these PVCs are secondary to ischemia, secondary to spasm. Treat the spasm, you get rid of most of this problem.
But I think there is a comment from Dr. Nahas about use of calcium channel blockers in coronary spasm.
Right. So I thought, okay, yeah, Dr. Abdulhab Nahas. So I thought calcium channel blockers are very effective in alleviating spasm. Correct. So typically, if somebody has spasm, I typically use a longer-acting nitroglycerin, and calcium channel blockers, I usually start with the nifedipine or dihydropyridine class, either nifedipine or amlodipine, but I trust nifedipine a little bit more. And in some cases with refractory spasm, you can use two kinds of calcium channel blockers in the same patient. So you can use two classes of calcium channel blockers. So yes, calcium channel blockers are very effective and used in treating spasm.
Yeah, there's a paper from Japan that they had a study for coronary vasospasm, and they used two calcium channel blockers in those patients. So two different classes of calcium channel blocker, dihydropyridine and non-dihydropyridines.
Right. I think Yousef will move to your next question because we took a long time in this.
Yes. Okay, so my next ECG, next case. So this is a, I'll go to the case first, 62-year-old male with history of hypertension, chronic kidney disease, hyperlipidemia, diabetes, obstructive sleep apnea, and aortic valve replacement. So what does the EKG show? I'll show you the EKG first. And then we'll go back to the choices. Okay, so the options are sinus bradycardia with high-grade AV block, sinus bradycardia and second-degree AV block, Moppett's type 1, sinus bradycardia first-degree AV block, or sinus bradycardia complete heart block and a junctional escape rhythm. This is the EKG again.
So what's the PR interval, Yousef? It looks pretty long.
It looks pretty long. So sinus rhythm, very long PR interval.
Mm-hmm.
And there's 1-to-1 AV conduction, just to make it easier. Type your answer in the chat box. Okay, we have number 1.
So Yousef, we're waiting for answers. What's the difference between choice number 1 and number 3?
So you mean maybe choice number 4, yani high grade AV block and complete heart block?
No. So I think I want to explain.
So high grade AV block is 2 or more dropped P waves.
Exactly. Yeah. So some people they need to understand the difference.
Yeah.
Okay.
Yeah, I was planning to also mention that, but yeah.
Excellent. Okay, we got plenty of answers.
Some people chose number 3, which is the right answer. The right answer is first degree. So here you can see the P wave. Okay, so P wave. There's sinus bradycardia. 1, 2, 3, 4, 5. So rate about 50 or so, 50 beats per minute. And first degree AV block, very long PR interval. So it's definitely more than 200 milliseconds. This square, this one big square is 200. And this other one is 200. So we're talking about 280 milliseconds, almost 300 milliseconds. So very long first degree AV block. Okay. And otherwise there's 1-to-1 AV conduction. So there's no complete heart block, no high grade AV block, and no, in this particular EKG, there's no Moppett's type 1. Moppett's type 1, you have progressive PR prolongation, and then a drop beat, and then a reset. The PR interval will be shorter. Okay. So, so the right answer is number 3, which is sinus bradycardia and a first degree AV block. So I'll show you one more EKG. It's the same case. Same options. So is it sinus bradycardia and high grade AV block, sinus bradycardia or a second degree, Moppett's type 1, or a sinus bradycardia and a first degree, sinus tachycardia, complete heart block, and a junctional escape. So make the choice, and please type it in the chat box. This is the EKG again. So to go over this EKG, so there's a P wave and a long PR interval. So I'm pointing to lead 2. You can see, can you see my, I think you'll see my laser pointer here.
Yeah, we see it.
Prolongation, yeah, P to R prolongs. And then there's a drop beat. Here you see the P wave, no QRS complex. And then there's a PR, so P QRS complex, shorter than this one. So progressive prolongation, drop P wave, and then again a short PR interval, or it's actually long, but relatively compared to this one is shorter. It gets longer, drop P wave. Again, PR, but here it's blocked, it becomes 2-to-1. Okay, so this is 2-to-1 AV block. Here it's a progressive prolongation and a drop beat, which equals to second degree type 1. So second degree AV block type 1, Moppett's type 1, which is winky back. Okay. Any questions about this? So I'm trying to show the difference. So first EKG, we had a type 1 AV block. Second EKG, progressive prolongation and a drop P wave. So it's Moffitt, second degree Moffitt's type 1. And then you can see in this later part the 2-to-1 conduction. So this is not a high grade AV block, not a complete heart block. And the right answer is sinus bradycardia, second degree AV block type 1. Any questions about this case? Any comments, Khalid or Fathi?
So Yousef, again, how do we define high-grade AV block? What's your definition of high-grade AV block?
Well, high-grade AV block would be, so it's not going to be a complete AV block. So complete AV block or third degree, there's complete dissociation between the A and the V. So there's a junctional escape rhythm, and the P wave are completely dissociated from the QRS complex.
Yeah.
But at high grade, there's 2 or more dropped or non-conductive P waves.
Exactly.
But there's some conduction. There's some degree of conduction.
Right. Exactly. I think high grade is bad overall. When you see high grade, to me means probably patient need a pacemaker. So I define it, if you see 2 P waves in a row they did not conduct with no good physiological explanation for that, that's high grade. I think it's useful, very nice to explain the difference for the audience, because some of them, they may not know the meaning of high grade AV block. Because usually when we talk about a block, we talk about first degree, second degree, third degree, and then bundle branch blocks, right? But the term high-grade AV block is not commonly used in the general, for medical student teaching, etc. So I think from the electrical standpoint, it's good to explain it. And as you explained, 2 or more P waves not conducted, and it's usually bad.
Sometimes I think of it, it's like the gray zone between the third degree and the Moffitt's type 2 kind of. I mean, it's an advanced AV block.
Advanced, advanced. Yeah. Typically bad unless there is good physiological explanation.
Even if the patient doesn't have symptoms, which it's possible, there's an indication for a pacemaker. What about second degree AV block type 1, Moffitt's type 1? Usually, if the patient doesn't have symptoms, is asymptomatic, there's no need for a pacemaker. But if there are symptoms, then there's an indication for a pacemaker. Now, in this case, we can still further discuss this case. I'm not sure if it's something that we need to talk about or just defer to some other time about this specific case.
Yeah, I think,
We can wait for if there's any questions from the audience about this case.
Yousef and Fathi, can I just ask you another question, both of you, since you've been discussing what's the definition of high-grade AV block? So how do you differentiate what's the difference between high-grade AV block and intermittent complete heart block?
Both are bad.
But so, you describe Yousef and Fathi in high-grade AV block as 2 dropped P wave, as in 2 P waves with no QRSs. Mm-hmm. Is that not also describing intermittent complete heart block?
Paroxysmal AV block is well described, and it can be episodes of non-conducted complete heart block or even high-grade AV block. Could be both, because the paroxysmal AV block is more of a clinical diagnosis. But if the EKG diagnosis, it could be either high-grade AV block or third-degree AV block. I mean, that's how I look at it. If this would be the most appropriate explanation. Because the EKG has dynamic changes. Like, for example, look at this one. So if we just disregard the first part of the EKG, you'll have 2-to-1 AV block. Okay, so we'll call this 2-to-1 AV block. Do you agree? So if we just exclude the first several beats, we just look at the last 2 beats. This is a 2-1 AV block. With a 2-1 AV block, you can't tell, is it a high grade? Is it a Moffitt's type 1? So it has to be within the context. And if you look at the first part of the EKG, it's very clear that this is a Moffitt's type 1.
So Fathi, what's your difference between high grade and intermittent complete heart block?
So,
or are they the same?
I think they're relative. So let me put it this way: when you get complete AV block, if somebody have complete AV block, means there's no communication between the atrium and ventricle, and that by itself is a high grade. That's a high grade block, right? Complete heart block is a high grade block. Now, but at times you have transient high grade block, but you don't have, it depends on the pause, you don't have a ventricular escape rhythm. So, and then conduction starts back with AV conduction, but without saying what's the underlying ventricular escape rhythm. That can be very long, and the patient can have symptoms like syncope, or could be very short, like as short as 2 beats. So I think it's a spectrum, Khalid. And I think I don't know specifically if there's any way you can define this or that. I think both are bad, and you need to take them into context. As long as there's no physiological explanation, other physiological explanation that's reversible, both of them need to be taken quite seriously.
When I've seen paroxysmal AV block, I've usually seen a transient complete heart block. Given that it's not vasovagal, I really need to rule out vasovagal. Usually it happens in someone who's older patients, they have some underlying bundle branch block or trifascicular block.
I agree.
Right.
I think, Yousef, there is a question.
The post-aortic valve replacement, that several times.
Yes,
Usually,
but,
planting pacemaker. Now, Muhammad has a question, a good question. Do you do his bundle study before deciding about need for pacemaker in asymptomatic second degree AV block? I mean, excluding multiple type 2. That's a good question. So basically, Muhammad, this patient has aortic valve replacement, diabetic, hypertensive, older patient. The other thing that would suggest that this patient would need an EP study, though he's asymptomatic, is his incomplete, relatively incomplete right bundle branch block and his left anterior fascicular block. You can see here that he has extreme left axis deviation. And so in this patient, actually, this patient has had some questionable syncope in the past. He has aortic valve replacement. So for this particular patient, yes, I would do an EP study. Now, what about someone who doesn't have a EP aortic valve replacement, just a 60-year-old male with history of hypertension, has paroxysmal episodes of Moppett's type 1 on Holter monitor? And what I would do is do an exercise stress test, have that patient walk on a treadmill. Or even this guy, if you want to, don't want to do an EP study, exercise stress test is one modality, non-invasive modality, where you can have the patient exercise with an increase in their heart rate, with an increase in sinus rate. If they have a benign form of conduction system disease, they should have one-to-one conduction. But if they have conduction system disease, then you'll see advanced form of AV block with increased heart rates.
But here, just a comment for you. Do you ever use atropine instead of exercise?
Unless the patient cannot exercise, I typically put the patient in the treadmill, ask them even to walk and look for their heart rate trend. Unless the patient, is post-operative or cannot exercise, and you want to challenge them, so sometimes use atropine. And
so with atropine, the conduction, if the patient has advanced conduction disease, the conduction should get better.
No,
because you're slowing the, or actually, I'm sorry, atropine would increase the heart rate. I'm sorry.
Right.
Or isoproterenol, that's the other thing. Right. Isoproterenol.
Yeah, so it's, yeah.
Yeah.
I think
what I was trying to say is carotid sinus massage. Carotid sinus massage you should have better, but we won't go that route.
Yeah.
So isoproterenol or atropine.
Yeah, I think we need to, otherwise we spend too much time on the heart block, so I think we need to move to that other case. Yeah, very, very interesting, Yousef. Very interesting case.
Okay, we'll move, Khalid, it's your turn.
Okay. So we'll go to our second case. This is a 29-year-old female who is otherwise fit and well. presented to the emergency unit with mainly palpitation and breathlessness. And that's her presenting ECG. So I'll give you 15 seconds to look at the ECG. So I'll show you the ECG again, but I'll just give you the potential diagnosis. What do you think the likely diagnosis is? Do you think this is supraventricular tachycardia with aberrancy? Do you think this is ventricular tachycardia? Do you think this is paced rhythm? Or do you think this is pre-excited tachycardia? Do you think this is electrolyte disturbance? Or is this actually an artifact? So I'll show you the ECG again. And I'll show you ECG with options. So if you could type your answer in the chat box. Good. Well, so what we could conclude from this ECG, that we probably all agree that this is broad complex tachycardia. And the list from A to F is basically the differential diagnosis of broad complex tachycardia. So we've got couple of answers. So one, is this artifact? We also had someone voting for SVT with aberrancy. So what I do is whenever I have a case of broad complex tachycardia, there is different way of differentiating between VT and SVT with aberrancy or pre-excited, but none of these algorithms, whether Brugada or Griffith algorithm or Barsagi algorithm, none of them is perfect. So even for us as electrophysiologists, we don't always get it right. So that's a good starting point. The teaching in medical school and when you start practicing, if you're in doubt or if you have a high-risk patient, it's always safe to treat it as VT, as ventricular tachycardia. But I could reassure you that this ECG was repeated several times and the patient was feeling unwell and describing palpitation. So we all happy to exclude artifact. The patient also had observation and blood test and all of her electrolytes were within normal range. So now we managed to exclude 2 out of our 6 potential. Number 3, paced rhythm. You could initially see that there is some spike. You could see it in some lead, but in not all complexes. And from first impression, you think, well, is this a paced rhythm? But when you ask the patient, she doesn't actually have a pacemaker and doesn't have an ICD. And her chest X-ray didn't show any cardiac device. So we could all happy exclude paced rhythm as an option. So now we came to really, it's one of 3. Is this SVT with aberrancy? Is this ventricular tachycardia or pre-excited tachycardia? So I'm going to talk to you about my approach. Again, there is no perfect approach how to differentiate between different types of broad complex tachy. Specifically, how to differentiate between SVT versus ventricular tachycardia. But there is different algorithm, Brugada and others. None of them is perfect. But I always start with what is the most sensitive and most reliable criteria. So if this is SVT with aberrancy, So we should expect typical aberrancy. I put a mark here to say that this is provided that you look at the QRS morphology during sinus rhythm, and provided your sinus rhythm morphology is normal, then this criteria will almost always give you, I wouldn't say that 100% answer, but will give you a very good clue to whether this is SVT with aberrancy or VT. If you have a typical bundle branch block, then this could be either. It could be SVT or aberrancy. However, if you don't have a typical aberrancy, means it's not typical left bundle or typical right bundle, and provided your resting ECG QRS looks normal, then this have to be VT. So the only way where it's helpful, if you have atypical bundle branch block and your resting ECG is normal, then this is almost always, you can't be certain, but you can with confidence say this is probably VT. So for us to be able to say this is typical or atypical bundle branch block, we need to know what the typical bundle look like. So in this graph, this is what a normal QRS. Whenever I look at deciding whether this is a typical bundle or not, I always look at two leads. Usually V1 and V6. So normally in V1 you have initial positive deflection, then you have an S wave, whereas in your V6 usually you have a small Q and then a very positive R wave. So this is your typical normal. In the right bundle, we have what it's called as an M shape or rabbit ear. You'll have the initial deflection R, then deep S, then R prime, and always your R prime, the second component, is bigger than your first R. More importantly, and this is really important, that in V6 you still have the prominent R wave, then you have a deep S. This is for typical right bundle. For typical left bundle, you always have this negative in V1 with almost a W sign, and positive in V6. So almost always in V6, in typical bundle, whether it's right or left, you should have a prominent R. In right bundle, you should always have a deep S as well. So if we go back to our case, we go back to our ECG. So when we look at V1, you get the impression that there is R, then R prime. The second R does look bigger than the first R. Okay. You could still think this is typical, but when you look at your V6, you see that your R wave is so small and you have very deep. So this is not in keeping with typical right bundle. The resting ECG was completely normal. So for me, this make SVT with aberrancy is very unlikely. So I know from my first criteria, almost always this is VT. The second thing I look at is, remember for each criteria there is limitation, but this is kind of advanced ECG. For ventricular tachycardia, you don't expect good AB relationship. Sometimes you do, but typically if you see there is no, there is AB dissociations with the V more than the A, means there is more ventricular signal than A, then this is again is in keeping with ventricular tachycardia. It's always important to look at the tachycardia, whether is it regular or regular. You still can have irregular ventricular tachycardia, especially with the polymorphic. Then also, I won't go into the details now about the QRS concordance in the chest lead. Brugada criteria suggests if you have positive or negative concordance in the chest lead, then this is suggestive of VT. My tip to you is negative concordance is very suggestive. So what I mean by negative concordance is if you have QS, which means your QRS is always negative from V1 to V6, all of them are negative. Obviously, in this case, is not because it's positive in V1, V2. Then this is very suggestive of VT. If it's all positive in the chest lead from V1 to V6, this is suggestive of VT, but in some advanced EP cases, we know that could still be pre-excited tachycardia. So my tip to you today is positive concordance in the chest lead is useful, especially if it's negative concordance, which is in keeping very likely to be with VT. Positive concordance, just be careful. It's likely still to be VT, but make sure you rule out pre-excited tachycardia. I hope I haven't confused you, but the message from this case is not single algorithm available is 100% accurate. There is limitation to every criteria, but my typical way of approaching any broad complex tachycardia is always to interpret the tachycardia ECG with relationship to the resting ECG if it is available. I start by looking at, is this typical bundle or not? If it's not typical bundle, then it's likely to be VT. If it's a typical bundle, then really doesn't help you because it could be still either, whether SVT with aberrancy or VT. AB dissociation is very helpful when you don't have a constant relationship, and especially if the V is more than A. This is again is suggestive of VT. QRS concordance in the chest lead, especially when it's negative, is very suggestive of VT. Obviously, also, I don't have an example here, but we have captured beats, which means that through the tachycardia, the sinus node managed to activate the ventricle, so you will see a narrow complex, which is look like a normal underlying rhythm in between the broad complex tachycardia, or a fusion beat, which is essentially a beat which looks somewhere in between the sinus beat and the broad complex tachycardia. So it should be somewhere between narrow to broad, which means the ventricle is activated both from the sinus and from the ventricle, from the ventricular tachycardia. The other message, which is really important, if you have a resting ECG, it's really important to look at the resting ECG and to compare it with the tachycardia. So the message from this case is broad complex tachycardia. There is 6 differentials. We mentioned this in our question. If you are in doubt, always treat it as VT, especially if the patient is unwell. Remember, there is no perfect algorithm available. Even Brugada has limitations. I always start with what is common and more sensitive. There is more criteria about measuring the QRS duration from initiation to the nadir, or if there is a deflection. None of them is absolutely 100% sensitive. But to show you, to confirm in my case, I was happy from just looking at the first criteria where I've proven this is not typical right bundle, because the V6, there is very small R wave. We've taken this patient to the EP lab, and I just want to make it simple. What you see in here is your ECG, lead 1, lead 2, lead 3, and your chest lead here. This is the tachycardia, but I also put here at the bottom a catheter where we measure the atrial signal. We put it in the high right atrium, so that's what we call HRA. And this measures the atrial activation, and you could see that the ventricle, there is more ventricular signal, more QRSs than A. For example, here, there is no A. So you could see that the ventricular activation is more than A. So this is, again, very suggestive of ventricular tachycardia. This is just the arrows to show, just if you compare the ventricular activation, the QRS on your V6 with the atrial signal, you see that there is more blue arrows than red arrows, which means there is VA dissociations, and more importantly, there is more V than A. I won't go into the details whether this is retrograde or antegrade conduction, but this is just to confirm that this patient actually had ventricular tachycardia, which was successfully ablated in the EP lab. So again, the topic of differentiating between VT and SVT with aberrancy is beyond the scope of this meeting, but this is just to give you a flavor of a broad complex tachycardia and how I quickly approach this case. So I'll just see if there is any questions. I think it looks like if I go back to the ECG, and there is a couple of questions. So one question is, there is a notch represent the P wave. I always, this is what I learned from my mentors. We always get difficulty interpreting ECG when we try to look for some P wave. So one of the problems is over-interpretation of the P wave. I honestly will not say with confidence. I could see you may, because I'm sure there is some, but can you say with confidence that this is, for example, a P wave here, or is this just interventricular delay? I honestly can't be with confidence saying that I could see any P waves. With regard to the other question, which says that I am, someone is confused with the shape of the T wave. This is something we discussed. What you see in the T wave here is likely to represent an artifact spike. You don't see it in all. For example, if we look at lead 2, you could see that there is spike in here, but then you don't have it here. It's something is likely to be a limitation of the ECG recording. It's likely to represent an artifact. I'm not sure it's anything else more than that. I could reassure you that this patient I have ablated successfully, and she does not have a pacemaker or an ICD. Yes, very good question from Dr. Anas. Without just complicating this case was Vesicular Vt, which is very common in young patients with normal healthy valve. Usually they respond very well to calcium channel blocker, specifically verapamil. In fact, some physicians, they call it verapamil sensitive ventricular tachycardia or Balhasian ventricular tachycardia. These patients do very well with verapamil, and also this could be treated successfully with ablation. And in this case, the patient was not keen on taking medication for the rest of her life and opted to go for ablation, which was successful, and she's done very well. Just wonder whether there's any more question. Any comments, Yousef or Fathi, while we're waiting for any more comments or questions?
Go ahead, Yousef. Do you have comments, Yousef?
Yeah, a very good case, Khalid. Excellent case for a vesicular VT, posterior vesicular VT, based on the morphology. You can see the right bundle, though it has the bunny ear, so it almost looks like typical. It has a deep S wave in V6, but it has also the extreme left axis deviation. I think the confusing part is the spikes. I mean, I'm not sure if the ECG, I think my understanding that some ECG machines would artificially put spikes on wider complexes, like on telemetry. If the patient has a pacemaker, we can make an option that the patient has a pacemaker, and then the device, the telemetry itself artificially puts spikes, and that can confuse the basically the techs and the nurses. So I'm not sure what would explain the spikes here.
Yeah, exactly. I think I agree with you. I think it's probably a limitation of the ECG recording, and it's probably just an artifact, but there is no other explanation. I don't know. Any comments, Fathi?
No, I have no. As I said earlier, this is sometimes the machine, like Yousef said, the machine adds those to make it more clear, but sometimes it's confused. I don't understand the mechanism by which the machine decides to put some spikes or so. So, yeah, I think it's not right. It may confuse the picture a little bit. I have a couple of comments on it.
Yeah, Fathi, before you go, I want to add about this spike, and then we'll take your comments.
Right.
So the main thing is this spike. You know that it's if you expect it to be a pacing spike, obviously this doesn't fit with pacing spike, because you could see that the timing is wrong because it's on the T. You could argue that it's pacing and it's not capturing, but if it's a pacemaker, you expect it to be either just before your ventricular activation or before your atrial activation, whereas here it's mainly labeling the T wave. You could see it in V1, even though this is negative, and in the V6 you could see it on the top of the T wave. So it's probably limitation of the algorithm for the ECG recording machine. So I agree with you. Fathi, go ahead with your comments.
Yeah, so the first comment, I think more audience answered this to be A, which is SVT with aberration, which is very expected, as you know, for several reasons. Number one, it's relatively narrow. It's a broad, like I said, broad or wide QRS complex tachycardia, but it's not super broad because it's vesicular. And so many of those patients, because of their younger age, and most of them, they are sensitive to adenosine. You give them adenosine, calcium channel blocker, or even beta blocker will terminate tachycardia. So many of those patients will end up seen in the emergency room or in the outpatient department and treated with those medications before they get recognized as this to be a ventricular problem, ventricular tachycardia. So this is not uncommon. So this is the first comment. So lots of people will treat them as SVT. The second comment I have, Khalid, about the intracardiac Egm. Can you bring that slide so I can? I think it's very interesting. Very nice case, by the way. I love it. Yeah, this one here. Yes. Or this one, actually. This one is good. This one is perfect. So here, let me just make a comment, because this is beautiful. I think the longer to monitor these patients, the better. And I typically, when you go to the intracardiac electrogram, sometimes it shows you what do you see on the surface EKG. So just for the general audience to know, the QRS complex here is running at a 50 speed, probably, or 100 speed. I don't know which speed, Khalid, but this is a faster speed than your regular EKG. So that's why the QRS complex and everything looks wider here. Okay, so that's because of the EP lab, you run at a faster speed. But the interesting part here, and the patient has some sort of AV dissociation or inconsistent AV relationship. So you see some atrial activities. Ventricle is fast. Ventricle is the source of the tachycardia, so it's fast. It does not stop. But the atrium is inconsistent, regardless. And this is not the point of discussion whether there is a VA conduction or not. But there are some gaps. There are some gaps, like this gap and this gap, where there is no atrial activities. There is an opportunity, if you look carefully at the longer rhythm strips and on the telemetry. I don't think we've seen it in the 12-lead EKG. Khalid brought it, but in the telemetry, what I do is just you go from here and you go up. So this atrial activity, you will capture it at some point in one of the leads. And if you look here, if you look at this T wave here, there is a little notch there. You see that? And then, so that's the P wave, and this is the P wave. And here, where there's no atrial activity, you see that notch is gone. So you see this notch, you see this notch, you see the notch everywhere, and you can tell in this beat here, the notch is gone. So, of course, now we know this because we're looking at the intracardiac electrocardiogram. So I can tell you 100%, and this is in continuation to the question brought earlier by a couple of the audience about the T wave and the P wave. So we know the P wave in this patient should lie somewhere here in this part of the T wave, and the fact you don't see it here indicate this is diagnostic of VT. This is V more than A. This is diagnostic of VT. Of course, you need to, you may not see them in all leads. In this case, probably is going to be more visible on lead V1, and probably not all the time, because if the 12-lead EKG capture everything like this, it's hard to tell what's this much. But you have to screen your T wave carefully. And if you find big difference like this and this big difference between T waves, and that may tell you that there's some sort of AV or VA inconsistent relationship. We cannot say the association because we don't know what's the VA relationship. So I thought this is beautiful, Khalid. What do you think?
No, I agree. I think here we have the advantage of the intercardiac, which I agree, Fathi. But when you see it in resting ECG, sometimes it can be difficult. Sometimes it can be very easy, but here I agree. It's especially in V1, you could see it really nicely there. So
that's why I think a longer monitor. So sometimes if you have a patient like this, I would go back to the telemetry and look more and more and more, and try to screen certain leads where just look at the T wave, ignore the QRS complex, just look at the T wave from the beginning till the end to see if there's any specific differences, and that may give you a hint about the morphology. There's a question, Khalid, about why vesicular Vt.
Yes.
Mm-hmm.
Yeah, so essentially this is why most algorithms are so difficult and cannot be accurate, because I've chosen here a vesicular Vt. We know vesicular Vt is originated from the fascicle. So it's not the typical Vt, you see it arising from the ventricular myocardium. And this is why the vesicular Vt has a property related to the conduction system, the His-Purkinje system. And this is why it's sensitive to calcium, and it can look like a typical right bundle or typical left bundle, and it does tend to be narrowish, or it can be just slightly broader. So that's why vesicular Vt is one of the Vt where it can be extremely difficult to differentiate from SVT with aberrancy. And this is why it's been noticed that it's sensitive to verapamil, because it's originated from the fascicles. So that's the answer. Anything else to add, Fathi or Yousef?
No, I don't. I think I totally agree.
Yeah. Right. I think we spent too much time, and it's a very hot topic, this differentiating between VT and SVT. But the key teaching is, if you're in doubt, always treat it as VT, and there is no perfect algorithm. So Fathi, I think it's your case now, if you want to go next.
Okay. Can you bring the slide, Khalid? Let's see. Yeah, thank you. Okay, next, I think. Okay, so Ekg Number Two. So this is a younger guy. We're getting younger and younger, right? So
yes.
This is an 18-year-old man who was brought to the emergency room with rhabdomyolysis. So rhabdomyolysis, I hope I spelled it correctly. I think there's O after the Y. So the patient has rhabdomyolysis and was found on the floor, on the ground, and his CK was 150,000, more than 150,000. So this was his EKG in the emergency department. And so I give the audience a couple of few 20 seconds or so to look at this. And the case patient was asymptomatic. He does not have any chest pain, but he looked ill. And the cardiology were called because of possible ST segment elevation, which, let's see if I can get my mouse. So there was comment about ST segment elevation in these two leads. So there was some concern because the machine called this an MI, but the patient was asymptomatic, but the CK was high, etc. So this was the EKG. So I give everybody some short few seconds to see this. And I think I hope I have the questions put correctly. Otherwise, I may need to jump to another slide. Khalid, you may need to help me with this. Let me see. So yeah, exactly as expected. So the ignore this. This was the question for the first case, but let me just show you the. Can you, Khalid, jump to the questions of the first case, please? Can you move the slide of the first case? Yeah. Case number 1. I get them mixed up, fortunately. Yes, this one here. So what's the underlying problem for this EKG? So number A is hyperkalemia, number 2 Brugada syndrome, number 3 acute septal MI. So please try to remember those because we're not going to go back to the slide. So A is hyperkalemia, B for Brugada syndrome, and C for acute MI. I should put acute septal MI number A, right, to remember it easily, Khalid. So hyperkalemia A, Brugada syndrome B, acute septal, please enter your answers. And if we go back to the slide, Khalid, if you don't mind. Thank you. So A is hyperkalemia, B Brugada, and C is acute septal MI. So make your choice. If you want to move your laser pointer, Khalid, so we wouldn't confuse people, or Yousef, who has his laser pointer in the screen. Okay, so B is what? B Brugada, so we have 1 Brugada, 2 Brugada, and A hyperkalemia, and then another Brugada. So we have 2 B for Brugada and 1 A for hyperkalemia. Maybe give it maybe 15 more seconds, see if there's any more comments. Brugada pattern, yes, I like the word Brugada pattern. Yeah, and we're not going to spend time, Khalid, in Brugada and Yousef in Brugada because that's going to be a long discussion. We're just going to discuss the etiology of this case. So, so the answer is in fact hyperkalemia. Ignore this. So the patient has acute renal failure because of its rhabdomyolysis. His potassium was 7.3. Patient has a pH of 7.2. His sodium, I think, was in the 138, 139, so mildly hypokalemic. So the patient's potassium was elevated. They fixed the potassium. They gave him insulin and glucose and calcium. And then this is in an hour and a half. Repeat EKG is completely, perfectly normal, or most of it. As you can see here. So the changes we've seen earlier resolved after fixing potassium. So this was not the most classical case of hyperkalemia related EKG changes. That's why I thought we'll probably use it as an opportunity to discuss the effect of potassium on the EKG. Yeah, so somebody said T wave was peak 2. That's a great point. So let's go back to the EKG. So these are the EKG changes in hyperkalemia, and we'll go back to the case in a second. So in hyperkalemia, you get peak T waves, but you may have some peak T waves in a normal variant. The difference is in the hyperkalemia, the base is usually narrow, as opposed to the base is usually wide in a normal variant, and the T wave here is usually spiky. So more spiky, more so than in a normal variant, or sometimes you find the ST segment elevation and peak T wave in hyperacute MI, which is also can give you this pattern like the case we've seen earlier, the case of a spasm. So, so it's very important to comment or to notice the base of the T wave. So if it's narrow and tall, that's suspicious for hyperkalemia. The question is how tall is too tall, or how tall is abnormal, and discussion about more than 50% of the concomitant R. I find that to be relatively subjective in many times, but 50% or more of the concomitant R wave is reasonably acceptable in general. So hyperkalemia can affect almost every part of the EKG. Typically start by affecting the T wave, but later on it can affect the QRS complex as well as the P wave. So it starts by affecting the T wave, and also what it does essentially, it spikes the T wave, but it stretches everything else. Everything else gets stretched. So if you imagine you stretch this part, the QRS complex gets wider, and the P wave gets wider and slower. So as the hyperkalemia progresses, you see this P wave here that is very nicely demarcated. It gets wider, broader, and smaller until they disappear later on. Same thing for the KRAS complex. You see the KRAS complex here is narrow, relatively narrow, but as the hyperkalemia progresses, the KRAS complex gets wider and then gets wider. And in advanced cases, you just go to the spectrum of hyperkalemia here. So start by peak T waves, and then you go to gradually you lose your P wave amplitude, gets broader, and then KRAS complex gets wider. And at the very advanced stage, when the potassium is closer to 8, your patient may end up having a sine wave pattern or ventricular fibrillation. So it's a spectrum affecting all the KRAS complex or all EKG elements, but in a different pattern, spiky here and loss of the amplitude in the others. If I go back to, if I go back to this EKG of the same patient, the one we've seen earlier, this is his potassium. This I chose only lead V4 through V6, or some of the precordial leads. So this was his potassium. When his potassium was 7.3, you can tell that the P wave were broad. You can see it probably more in this lead here. You see the P wave, how broad they are. And after potassium is normalized to 4.1, you can see the P wave are back to normal here. PR interval is longer here. And also look at the KRAS complex. So the KRAS complex normal is quite narrow, but look at this KRAS complex is kind of wider. You can see it more noticeably in this beat compared to this beat, for example. And of course, you got the sharp, spiky, tall P wave that has a relatively narrower base compared to the others. There's a mouse in the way, either Yousef or Khalid, you have a mouse and a laser pointer on the screen if you move it out, so don't confuse people.
Khalid, maybe it's yours.
No, and then there's another mouse, another one. So the last thing I'd like to comment about in this case, if we go back to this EKG, so I don't know which mouse is this, Khalid.
Might be one of the other screens, because if you have two desktops.
Right, so maybe somebody else, sure. So here you can tell there's subtle changes of hyperkalemia. You have the peak T wave here, you have the peak T wave here, but also you can tell, you see those broad P wave, the wider KRAS complex. So putting them together, it kind of raises suspicion about this degree of hyperkalemia. Now, let's go back to the first and why this patient was more, alerted by the ER doctor is the pattern here. So so there's some ST segment elevation, minimal, you can see it here, more prominent in lead V2. And it has kind of some degree of Brugada type EKG, or some people call Brugada Finokabi, where this is concave, and here there's some hint of T wave inversion, and this is almost like Brugada type 2, which is subtle. So there's some suspicious EKG changes, but only limited to V1 and V2. And interestingly, it turned out that you can see those changes in hyperkalemia. For me, this was the very first case where I've seen Brugada type EKG in hyperkalemia, although I heard about it before, but this was very, very first actual case I had, and this from only a couple of weeks ago. So when I looked it up in the literature, apparently there is some case reports about hyperkalemia-induced Brugada Finokabi. It's a rare EKG manifestation. This is the patient on the article. This is not our patient. This is a patient from the case report. You can tell here it's kind of more classical Brugada type changes in only lead V1, V2, and you have the other signs of hyperkalemia here where the T wave is peaked, etc. and this is the patient's, again, in the case report where EKG normalized and he lost the Brugada type EKG. So for me, this was the very first time I see a Brugada type EKG in hyperkalemia, in addition to the other relatively subtle changes. Okay, so I think that's it, Khalid, for me. If you have any comment, you or Yousef, or any questions from the audience about this case.
Fathi, very interesting case. Could you go back to your ECG? Yes.
Mm-hmm.
So I think we discussed this. It's with the Brugada feature. It's obviously the typical Brugada type 1. You'll have a right bundle morphology and ST elevation more than 2 millimeter, specifically in V1 and V2. But you tend to have a negative T wave, as shown, I think, in the case report. But sometimes you may not be able to see that very clearly, and you have to put your ECG stickers in a higher position. For example, 1 and 2, there will be one space higher than the usual position, and then you may be able to see it more clearly. We also, obviously not in this case, but if you're in doubt about a patient whether they have Brugada or not, sometimes we may provoke by giving flecainide or ajmalin. But nice case, I've never seen it. And Fathi, did you only see one case report? That's it, no, nothing else been reported?
Oh, no, I didn't do a full search. I just looked quickly. As you know, I am lazy. So the first thing I did, I Googled at the same time where I was talking to the EDoc on the phone. I told him, well, that's interesting. This looks like Brugada. And when I talked to him, I just searched it and I pulled this article and sent it to him. But I didn't do a full search, Khalid. It's worth looking it up, though, to see if there's how frequent is this. And maybe some of the audience or Yousef have seen it before.
So I've seen during my fellowship one case of hyperkalemia induced like Brugada pattern. One case. So I can't remember the EKG finding, but it looked like a Brugada pattern EKG type 1. Patient presented to the ER with, I think he had hyperkalemia. I can't remember if he had rhabdomyolysis or not. But Brugada pattern, I mean, nowadays we get a lot of consults for Brugada pattern EKG. I mean, even in the ER for patients who present for different things, and they either, like Khalid mentioned, they put the EKG in the third intercostal space and second intercostal space other than the fourth, and then it looks like almost a Brugada type 2 pattern, and we get consulted for that. Or other cases I've seen cocaine-induced Brugada pattern EKG, or of course I've seen a case of Brugada syndrome, well, not syndrome, but Brugada pattern EKG in someone who has fever, typical Brugada. Came in with pneumonia, had fever, a young guy, but no history of syncope, so was treated conservatively. So,
but what was the reason this patient had rhabdomyolysis?
So this is interesting. So he's a young guy. There was some discussion about he was taking marijuana and he had some fight with people, and
right.
This happened after the fight. So he was found on the floor. And they think rhabdomyolysis happened because of that. Interestingly, so he needed dialysis, and he ended up having a compartmental syndrome in one of his legs. So they did the fasciotomy because he had a peroneal nerve damage. So he ended needing some surgery to relieve the peroneal nerve. But it was rhabdomyolysis, kind of traumatic from trauma. Interestingly, in that very case report, Khalid, and inshallah I'll send it to you and Yousef to look at it as well. The case in that one of Brugada type EKG and hyperkalemia was also a rhabdomyolysis case. So I cannot find a way to link rhabdomyolysis, because eventually you get high potassium and cause this. So I don't know if there's any other factors released in rhabdomyolysis can predispose certain. I have no idea. It's very interesting to notes that both cases, that at least this case and that case, was due to some rhabdomyolysis. I'll send you the report, and if you can think of anything interesting, let me know. That was the cause of his rhabdomyolysis.
Well, Fathi, thank you very much. I think now we move on to Yousef, final case. So Yousef, if you want to get your presentation on.
So this is my final case. I don't have much history, but I just wanted to show you the EKG finding. So based on this EKG, what is the likely diagnosis? This ventricular tachycardia, sinus tachycardia or left bundle, atrial fibrillation and pre-excitation, or atrial fibrillation and left bundle branch block. So it's a wide complex. It's irregular.
What are the choices again, Yousef? Can I see them again?
Yeah. So is it VT, sinus tachycardia, and left bundle branch block, AFib and pre-excitation, or AFib and a left bundle branch block?
Okay.
And pre-excitation means WBW conduction or accessory pathway conduction.
So choices A, B, C, D, or 1, 2, 3, 4, right?
Yeah, 1, 2, 3, 4, A, B, whatever.
Okay.
So we have Layman answered AFib with left bundle.
Go back to the EKG, please, Yousef.
So based on Khalid's presentation earlier, he explained, a wide complex approach to wide complex tachycardia. We can use basically the same analogy, the same basis. So do you guys think that this is a typical left bundle or an atypical left bundle? You can look at lead V1 and then V6. Has the M-shaped pattern always in V6, V5, and then intracoid deflection, like the initial short deflection. And so this is more of a typical left bundle branch morphology. It's not sinus tachycardia because I don't see any P wave. It's very irregular. And once you see this area of pause or slow in conduction, I don't see any P wave. It looks like very fine, atrial fibrillation. I don't see any P wave. So it's AFib with left bundle. And it's not pre-excitation because the complexes all look very similar and there's no evidence of pre-excitation. You can have AFib and pre-excitation where you have different QRS complex morphology. So the right answer is AFib and left bundle. Again, this is just re-mentioning what Khalid said earlier. A typical left bundle has this morphology. V1 morphology can have this short intracoid deflection here, and this pattern in V6, which is based on delayed left ventricle activation, and there's no absence of septal or the Q wave basically, and because of the activation is going to be from the right to the left, and so this is a typical left bundle morphology. Any questions about this? It was kind of pretty straightforward EKG. We need this one after all the EKGs that Fathi and Khalid showed.
Yeah, can I comment to Yousef?
Yeah.
A very, very nice EKG. The problem in this EKG, sometimes if the patient have a lot of this part of the EKG here, the first part, and then people might call it VT.
Yeah, if you look at the first part,
right.
It looks almost regular.
Right. That's why longer you see
some variation. If you measure the R to R, there's going to be a subtle variation.
Right. Very nice.
But overall, there's a typical left bundle morphology.
Right.
And this is someone who has a cardiomyopathy, kind of a sick heart.
Yeah, very interesting.
Look at AVF; it's very fractionated. But so the take-home message on this is underlying AFib and left bundle branch morphology. I don't think, as Sam mentioned, there's pre-excitation. I don't think there's pre-excitation because the QRS complexes look
Yeah, maybe elaborate here, Yousef, because I think that's a good question about pre-excitation. Elaborate on.
I mean, with pre-excitation, it have different morphology. QRS morphology is maybe with different axes, shift in the axis, and then that would be suggested for pre-excitation. But for this particular EKG, I don't see that.
Right. So my comment about that, Yousef, I totally agree. So let me see if there's my comment about that. You're right. For pre-excitation, you have to have at least 2 or more population of QRS complexes. So they should be different, and you see some fusion beat between different QRS complexes. So you see sometimes narrow, sometimes wide, sometimes in between. But like you explained, Yousef, all of them look about the same. Let's take this one here, for example. Sorry, take this one here, for example. This beat, take it all the way from here to here. It's exactly the same beat, no change whatsoever in the QRS complex, same as this one here. So that almost itself exclude at least pre-excitation in this part of the EKG. Totally agree.
Yeah, I think I agree as well. So the first thing we could say safely that this is typical left bundle, and then there is no variation in QRS morphology. And then thirdly is, I think, which is really important, sometimes it can be really difficult, is to look at the resting ECG when the patient may be not in tachycardia, and if it looks the same morphologies bundle branch, or if you could see clear pre-excitation. But I agree. I think this is more in keeping with the AF and left bundle branch block. Any comments? Any? No. Right. I think Fathi, I'll move on to my next case. I've got a quick case as well, and then we will wrap it up with the last presentation from Fathi. So I'll go to my slides. Right. So this is my last case. This is again, like Yousef, is a very quick case, just spot diagnosis, and then hopefully it will generate some interesting discussion. So this is a 56 years old male who has a background of hypertension and is troubled with 3 years history of palpitation, and that's his resting ECG. I was wondering if you could make any comments about this ECG. So I'm not giving you any question here. I'm just opening the floor for comments. Any abnormality? Is this normal ECG? Do you see anything interesting? So we'll wait for 30 seconds for comments. I think while we're waiting for comments about this ECG, Dr. Mohammed Turki made a very nice comment, which I actually agree with. At the beginning of the ECG, it was somehow looks regular, whether this could be a flutter degenerated into AF. But one of the things we see sometimes when you have AF and it's fast, it can sometimes look regular, and there may be just very small variation. Eyeballing it, you think it's regular, but it may look irregular. Obviously, it's not uncommon for AF to organize into a flutter temporarily. So very nice comment, Dr. Turki, I think. But I agree. So going back to my case, I see that
we did mention if you measure the to R to R initially, there's some subtle changes. There's some
variation. Yes. Oh, sorry. Right. So going back to this case, yes, there is not. So there is comment that PR interval is short. So I'll just, yeah, I agree. Especially if you look at the V6, your PR interval is short, and there is a suggestion could be a delta wave. I agree. You could see the delta wave probably more clearly in V1 there. You could see the PR interval is short, and you could see the delta wave, which is pre-excitation of the ventricle, and you could see it also nicely in V5. So I agree, this is a pre-excited ECG in keeping with WBW pattern. And because the patient is symptomatic, you could argue this is WBW syndrome. So now the question I have for our audience is, where do you think the location of this accessory pathway? So I'll see if there's any comments, and then I will just briefly, in a simple way, I will describe my approach on trying to localize accessory pathway.
Maybe just, is it right or left, right?
Right.
Yeah, so type A. Type A and type B, do you still use them, Khalid, the term type A or type B, Wolf, Parkinson, White?
Negative, then it suggests it's likely to be right-sided. And we could see here in V1, the delta wave is actually positive. So the initial deflection looks positive. And if you look at V2, still positive. I think it's positive, still positive, still positive, still positive. So this is, again, what I look at is V1, whether is it positive or not. So if it's positive, it's likely to be left-sided. And then I'll see if there is any transition. What I mean by transition is if the delta wave go from positive or negative to the other way. But here we could see that the delta wave remained positive in all chest lead, which means this is unlikely to be septal, because if it's septal, you expect it to transition. And the transition in the delta wave activation is kind of helpful for localizing the site of the accessory pathway. But the fact that this does not transition, it remains positive throughout the chest lead, means this is likely to be lateral, left lateral. And we know it's left because V1 is positive. And then you try to support your finding with the shape of the delta wave in other leads. For example, if this is very left-sided and lateral, you expect it to be negative. And in AVL, and you see here the P wave and then negative. So this is again supportive. This is likely to be left-sided and likely to be lateral. And then the next stage I look at is inferior lead, whether this is anterior or posterior. And in the inferior lead, sorry. For example, if we look at lead 2, you could see the P wave, and then I think the initial part is positive. So this suggests that this is likely to be anterior. Sometimes if your finding doesn't fit in all ECG, where you expect the location of the accessory pathway, then you should think about two possibilities. One is whether you have a fusion of conduction between accessory pathway and normal AV node conduction, or whether you have two accessory pathways. So without complicating this, I mean, I know this is kind of advanced level, but for simple approach for localizing accessory pathway, the first starting point is this left-sided or right-sided? And the best lead to help you in that, in most cases, you cannot be at 100% sure, but V1, if it is positive, then this is likely to be left-sided. If is it negative, the delta wave is negative, it's likely to be right-sided. I personally prefer looking at the delta wave. There is some complicated algorithm looking at the QRS morphology, but I personally see the delta wave is the activations of the ventricle and suggest the site of the accessory pathway, but there is some algorithm are based on the QRS morphology too. So to recap, to decide this is left or right, you look at V1. If it's positive, left side. If it's negative, it's likely to be right side. Then I look at the transition. What I mean by transition is, does it remain positive or does it change to negative? If it changed within the first few lead, like V1, V2 or V3, then this suggests to be very septal. If it transitioned quite late, it means very apical or distal. Whereas here we could see that it doesn't actually transition, it's always positive even in V6. To me, this suggests this is left lateral. ABL is negative, which is again in keeping with left lateral. And I look at the inferior lead to decide whether this is anterior or posterior. If it's positive, it's anterior. If it's negative delta wave, then this suggests it's made posterior. But the take-home message is short PR interval and delta wave is a feature of pre-excitation WBW. To localize it, we look at V1, and then if it's positive, it's left-sided. If it's negative, if it is right-sided, then we look at the transition, how early is it. If it transitions from one direction to another, the delta wave, early on in V2 or V3, this suggests it's mainly septal rather than lateral. If it doesn't transition or transition quite late, then it suggests this is very lateral. And then you look at ABL and lead 1 and the inferior lead to help you decide whether this is anterior or posterior. This patient obviously went into the EP lab. Again, sorry, this is just an EP ECG with different speed. You could see that we managed to induce a pre-excited tachycardia, and this patient was successfully updated. So I'll just go back to the ECG. Again, this is just a short case. This can be quite complex, but if the take-home message is to be able to decide this is left side or right side, look at V1 and see how soon the delta wave transition to help you decide this is septal or lateral accessory pathway. I'll just open the floor for any comments from the audience and any comments from Fathi or Yousef.
Khalid, I just wanted to mention the traditional teaching of positive QRS complex in V1. What's the differential diagnosis? Just to mention to the audience, like when you see a positive QRS complex in lead V1, obviously this looks abnormal. It should catch your eye. Why would it be positive in V1? It should be negative. So one thing is WBW, RVH, just things to think about. Of course, in this case, it's obvious that there's a short PR interval and delta wave. So the other thing is muscular dystrophies also can be associated with a positive complex in V1.
And dextrocardia.
With the dextrocardia, those are the four things.
And
it's based on the activation. V1 is the most the lead that's closest to the RV, to the right ventricle. So anything that activates from posterior towards anterior, it's going to be positive in lead V1.
Right, and posterior MI, like one of the audience, that's correct. True posterior MI gives you right. That's correct. Yeah, that's typical. Question, Khalid, do you have an EKG after ablation? Would be nice to have it.
I was, this is sadly from my time in the US 4 years ago, so I couldn't find it. Okay. I was looking for it, yeah, but it would be nice to show. Yeah. I have EGMs, but sadly not an ECG.
Don't you always love it when you show it to the patient, tell them this is before, this is after, and they...
Yeah, I always do, yeah, but I when I was a fellow, I was mainly interested in EGMs.
And so you made a decision to do an EP study, an ablation based on symptoms of palpitation. So this is a WBW pattern EKG plus symptoms. So it's a WBW syndrome. And I think it was the right decision to do an EP study. But what if the patient doesn't have symptoms? A lot of times we get consults for incidental finding of WBW pattern EKG. So what would you do in someone who's young, less than 35?
I think, Yousef, this is a very important question, and it's open to debate, and different physicians have different view. And I guess this is what Dr. Naas is leading to. Is he's got the question here is, if the patient is needing EP for, look, do you need all these features if the patient is needing EP for? It's very hot topic. I don't know about your practice, Fathi and Yousef.
No,
but
the guideline 2011. Basically, anyone less than 35, asymptomatic WBW, exercise stress test. That's one of the, there's an algorithm. I use an exercise stress test. One of the other things is doing atrial pacing from the esophagus, esophageal atrial pacing. But I think an exercise stress test is the way to go.
I think, Yousef, for risk stratifications, I agree, exercise tests. But there is a growing evidence, and I think there is a paper in JACC where we know that exercise test is not as good as an EP study in assessing the properties of accessory pathway, whether is it safe or high risk accessory pathway. More importantly, we know sometimes with giving stimulant like adrenaline, we use isoprene in the EP lab. Sometimes you will need higher dose, or sometimes you induce very fast tachycardia during recovery. But more importantly, with exercise test, you only assess the antigrade. You could argue that the antigrade is the risk stratification because it's a dangerous one, whereas retrograde is not as dangerous. There is a growing evidence that, especially in the UK, I don't know if in the US they changed, that even for asymptomatic patients with pre-excitation, that they get offered diagnostic EP study. This is debatable. May not all physicians agree, but this is based on our experience that sometimes you do an EP study with a minimum dose of isoprene, and you don't, you find that the accessory pathway conducts safely. What I mean by safely is what we look in the EP lab is we see how fast the accessory pathway conducts, whether it can conduct very fast. Obviously, that means dangerous because if the patient develop atrial fibrillation and they pre-excite the ventricle, they can go into ventricular fibrillations. But we know that the exercise test is not as good. So I don't know.
Isopril, I have a reservation regarding using isopril to measure the antigrade accessory pathway, ERP.
No.
Not validated, I don't think that's validated.
No, I don't think it's looking at the it's looking whether you can use pre-palpitator.
Yeah, for induction of SVT, basically. That's what you're saying.
Yes. But also, I think this is mainly in our center. I think there is a case of one of my colleagues, and I think this is why it's really, I don't know, it's an experience. I know one case should not change the practice, but one of my colleagues, we had a case where the patient had an EP study, and there is debate about whether you should measure conduction property during isoprene or not. But that patient did not have isoprene, and the EP study concluded that the accessory pathway was safe. Sadly, the patient 6 months later had VF arrest. Fortunately, the patient survived, and only after giving isoprene, they induced AF, which was pre-excited and was conducting very fast. And obviously, the patient had an ablation and was successful. So I honestly, but Yousef, I know the guidelines suggest that for asymptomatic patients, they recommend exercise test. But if I ask 10 EP doctors, you will find most of them feel more comfortable doing an EP study. I don't know, Fathi, do you have any comments?
It's a long and complicated topic, as you know. But overall, I agree with your comments, Khalid, about it's very, most of what we do in this case are not extremely validated like in other cases. And it varies from patient to patient, from condition. For example, if this is a pilot or this is a commercial driver, truck driver, somebody, I definitely tell them we need, push them towards taking them to the lab. And when you're taking them to the lab, I would do everything. I would induce AFib, give them isoproterenol, and measure ERP. And of course, anything less than 250 or so. And then, especially if you induce tachycardia, and that goes pre-excited, and then tell them this is a high risk. At least I would not sign their papers for flying again or for, commercial driving. So I think it varies. If this is a 75-year-old man who's stable, who's quiet, who have it here and there, palpitation here and there, and then you may leave them alone. I mean, I think it's variable from patient to patient. Exercise stress testing, I tell you, I haven't done a lot for those patients. And the times I did it didn't, a couple of times I just did a stress test to see if the patient has, just because of borderline EKG, let's see if the delta wave would disappear suddenly during stress test. I wasn't very convinced that take me anywhere, unless of course if you have a big change, that's may convince you one way or the other. So I take it on case-by-case basis. And there are some EKG manifestations. If you put a Holter monitor on those patients for 24, 48 hours, sometimes you pick up some stuff that shows that this pathway is lousy. For example, if you have intermittent pre-excitation or long period of loss of pre-excitation, so you're either at rest or exercise, may indicate that this pathway is probably lousy, is not going to be very critical. I err more toward taking the patient to the lab and at least do a diagnostic study, so to tell them what's their risk, and if this is a pathway that's in an easy location to ablate with low risk of heart block and this kind of complications, versus this is a high risk ablation, low risk pathway, in which case tell them you're fine. If it's a high risk pathway, low risk patient, a high risk patient, low risk pathway, and then I tell them we're going to ablate it during the study. So this is the kind of approach we've been taking.
I agree. I think this is a topic beyond the scope of this webinar. So I think now we'll move on, Fathi, quickly, I think, to your last case, last short case, and then we'll get the meeting to a conclusion. So Fathi, I'll just put your presentation now.
Khalid, how about, I think it's getting probably late. How about if we just conclude here and make...
I think I agree, yes, getting late. Well, yes, Fathi, thank you very much, and Yousef, thank you very much for sharing with us really this interesting ECG. And thank you very much for everyone who joined us. And again, this is our first time using live broadcasting on Facebook. We felt that this is a way, hopefully, will be easier for everyone on the go, whether you're at home or away. You could join us whenever you have time. And we appreciate your interaction with us today. We hope that you will join us more often on eCardia. We're hopefully going to post a few interesting cases now and again. Any comments, any suggestion on how we improve this webinar or our website will be much appreciated, either on our Facebook website or on the eCardia website. Once again, thank you very much, and we hope you enjoyed it, and we'll keep you posted about our next webinars. And thank you very much again for attending. Thank you.
Thanks, Khalid.
Thank you, Khalid.